Hi everyone, welcome to a short lecture on androgens and some other miscellaneous men's health related topics that we haven't covered so far. We'll start with androgens and primarily just talking about testosterone. Testosterone comes in a number of different forms. It's used for quite a few different applications, and there's some synthetic versions of it available as well. I'm not going to go through all of this in detail, but this slide's here to review just sort of how the hormones work in a man and how things interact in the feedback loops and things like that. This will come into play too. We're going to talk about prostate cancer and BPH as well quickly. So just talking about testosterone in general, so there is a replacement product that exists, and it's essentially just testosterone. That's all we do. So we're just replacing the endogenous hormone, and that's the primary therapeutic use of testosterone. So there, again, I said there are some synthetic versions available, but we don't really use those quite as much. Those are more common actually as drugs of abuse for different purposes, mostly performance enhancing for athletes. So why do we replace testosterone? Well, some people have low testosterone levels. You can do a blood test and measure both total testosterone and free testosterone. Hypogonadism is a diagnosis that can involve either decreases in sperm production, decreased testosterone production, or possibly delayed puberty in boys. And there could be testicular or pituitary disease that causes a decrease in testosterone production for whatever reason. Those are kind of the primary bucket of diagnoses that would require testosterone therapy. And again, the mechanism is straightforward. You don't have enough testosterone compared to a normal man of your age, so you get replaced. You can bind directly to androgen receptors, and then it can also work just like endogenously produced testosterone would, so converted to DHT via 5-alpha reductase and be converted to estradiol by aromatase. And people need all those hormones as well. Males need all those hormones as well, even though we kind of think of those as historically female hormones. So testosterone is kind of the precursor to a lot of that. So it's important that in order to make sure all of our physiologic processes that involve these different hormones don't get disrupted, that testosterone is available. Testosterone, I put this on here. I'm not going to ask you the reference ranges on an exam, but just to show you how large the reference ranges of testosterone are for men of all different ages. And so there's a number of different age groups I put on there, but the range is still pretty standard. And it just shows you that you can have a really large fluctuation. So you can have somebody kind of on the lower end, and I think that might be where clinically things get complicated. Like, let's say you have a 40-year-old man who is complaining about maybe decreased libido and their testosterone tests on the low end of normal. Is it worth replacing at that point? That might be a clinical decision. But technically, you can be within that range and still be normal as far as different males go. And there's also, like a lot of hormones, there's fluctuations during the day. So it might be worth measuring on a different time of the day, or maybe even different week or different part of the month, potentially. Testosterone is highly protein bound, so free testosterone might be a better measure as well. It gives you a better picture of what actually is available circulating that can be used versus bound testosterone to albumin is not as indicative of that. However, the two generally should correlate pretty well. All right, clinical benefits of testosterone replacement. So if men are having difficulty with libido or sperm production, you can restore that with testosterone if somebody is low on the TN. Muscle mass increase. This is something that I would say is, generally speaking, the abuse component of testosterone. However, if you have an older, potentially cachectic male who, let's say, has some hormone disruption, I think of like maybe somebody post-testicular cancer, post-prostate cancer, something like that, maybe would affect some of this stuff. And so you might end up with using testosterone as a replacement therapy for that particular reason. So for muscle mass increase, you can certainly do that, but I think it makes sense if the person is already low on testosterone, not getting higher than normal levels of testosterone to be able to add mass. Bone density increase, so there is some studies that show that can be effective. However, again, it's going to be a backseat to therapies we've already talked about, like bisphosphonates. And the most important thing with that is that, again, the patient has to have a low T level before you'd want to increase or prescribe testosterone to replace it. Psychiatric effects have been studied with replacing T pretty significantly, and there's not a lot of good data for doing this. So there's been some studies on aging and cognition. There's been studies on mood, specifically related to subclinical depression, and the data is not really there to support either of those indications. Again, if your patient is low, sure, it might make sense to replace it. However, again, a lot of times we're talking about these maybe subclinical pictures where the person's on the lower end of what's considered normal. Delayed puberty. So the definition of this would be if you have secondary sex characteristics absent by the age when 95% of your peers would have initiated sexual maturation. If that's the case, you can initiate testosterone replacement to initiate puberty in those boys. General use for aging men, and this is sort of where testosterone therapy maybe gets a little bit controversial, is, as men age, testosterone levels decrease, and it's a question about, do you replace just so people maybe can feel a little bit more like a young man versus an older man? And that might be a conversation to have with somebody. I think there are some side effects we're going to discuss here. So I think generally speaking, that would be considered a non-therapeutic use, but still, I think it's done somewhat often in the real world. Just talking about the way that testosterone affects the different systems in an infographic here. Testosterone basically comes in every product imaginable with the exception of oral. It doesn't absorb well from the GI tract, so injectables, topicals are really popular. The most common one I probably see is the Androgel, which comes as a pump or like in little packets. And so you just pump out a standard amount and then you apply that to your skin and it absorbs. There's an axillary product that kind of would work like a deodorant, and you'd put this on prior to a deodorant, not as a deodorant, I mean, but like the same type of functional design of a deodorant stick. There's depot products, so like a thick, oily injectable that gets implanted in the muscle tissue and then absorbs slowly. There's this pellet that actually gets implanted right here, kind of above the buttock, and then that would be another long-acting releasing type thing there too. And there's a patch too called Androgens. So there's a bunch of different options, again, mostly long-acting injectable or topical related. Some things to think about with testosterone: be careful when prescribing testosterone topical products. If a patient does come in contact with children or women, it can easily absorb into their skin too. So there's like a couple of case reports out there that are kind of like puzzles because somebody maybe had a child that started undergoing puberty earlier than what was normal. So maybe like in their, infant years or something like that. And it's because they were putting testosterone gel or cream on their body and their child came in contact with that and got massive doses of testosterone. Generally speaking, it's not a significant long-term thing. You're mostly going to see short-term effects. And then once you take that steroid away, the effects should reverse themselves. But certainly better to avoid if we can. Most of the problems related to testosterone are going to be used with overcorrection or abuse. So generally speaking, it's a fairly safe thing to use. However, if you do have somebody pushing their natural testosterone outside of those limits we just talked about, that's where you can see more significant side effects. For example, dermatologic, acne, CNS, irritability, aggression, endocrine type things, GI related, PSA, prostate antigen increase. So you can have actually increased risks of BPH with testosterone replacement because you're getting more of a turnover into some of the other precursors that we'll talk about here in a second. But you can see that there's some problems that are probably more rare, like hepatic, renal, respiratory, likely not going to be significant. However, something to think about if you are, again, taking too much testosterone. All right, moving on to BPH. So BPH is mostly inevitable as men age. Their prostate is going to increase. It's not cancerous growth. It's simply just a a natural increase in growth that becomes problematic over time. So what happens is that testosterone gets turned into DHT, which is a much more potent version of testosterone, and it's a mediator of prostate growth. And this puts some pressure on the urethra and the bladder and causes difficulty urinating in older men. And you can see the prevalence, again, kind of will start for men mostly in their 40s, is where you'll see some incidents start to occur. And then by the time a man is in his 60s, 70s, 80s, it's almost a guarantee. I guess maybe I shouldn't have said every man, but you've got like 90% or so of men will experience some degree of BPH. And the older they get, the more common it's going to become. There's a couple different drugs we can use for this particular problem. There's actually 5 different things. So there's kind of 2 strategies I look at. One is related to the bladder itself. The other is related to the prostate. So the bladder drugs are going to be more commonly alpha adrenergic receptor products that work specifically on alpha receptors, and the more selective they are for the bladder, the more they are. These are alpha blocking drugs, so these are alpha antagonists, and what they're going to do is cause some smooth muscle relaxation. Muscarinic receptor, so there's some cholinergic type medications that specifically would work, anticholinergic medications that would specifically work on the M3 subtype, and that would work in the bladder without having anticholinergic effects in the rest of the body. 5-alpha reductase drugs are going to work directly on the prostate. These are going to work more slowly, so you're going to have a decrease in prostate size over time with these particular products, whereas the other ones will work relatively quickly to help the patient be able to urinate. And then we have phosphodiesterase type 5 drugs, and we'll talk about those. Those are more commonly used for erectile dysfunction, but they are actually pretty useful for this indication as well. So let's talk about these in more detail. You have the alpha-1 antagonists. These all end in osin. We talked about these a little bit with respect to blood pressure management, and I think I brought this up as a hypertensive option for patients, an antihypertensive option for patients with high blood pressure who are also having BPH-related problems. And so what these do is they relax smooth muscle and have relatively fast results. So if you have a patient with mild BPH-related symptoms, it might make sense just to start with an alpha antagonist because you're going to get fairly good results quickly, and they don't have a lot of side effects, especially the more selective ones. So terazosin and doxazosin are older drugs that have more broad use throughout the body. So, for example, they would work effectively as an antihypertensive agent, whereas tamsulosin, alfuzosin, silodosin, those are all newer agents that are much more selective for the specific alpha receptors within the bladder and prostate area. So you're going to get more of a directed approach that's going to have less impact overall, which is going to lead to less hypotensive effects, And if you remember back to our CV lecture, alpha antagonists have orthostatic hypotension as their biggest side effect. And so if we can get something a little more selective, you're going to avoid that side effect. That's why these 3 drugs here at the end would be generally more preferred, unless, again, you really wanted more of a antihypertensive medication, then these 2 would maybe be what you're looking at. And then the 5-alpha reductase inhibitors are commonly used in conjunction with the alpha-1 antagonists. Remember, they're just going to take a lot of time. So you're looking at 6 to 12 months of a reduction in prostate size. It's not to say it takes that long to get relief, but you're probably going to take at least a couple of months before the patient notices anything, and a full year before you're probably going to see the maximum impact of the therapy. So it's more of a long-term strategy. The 2 drugs here are finasteride and dutasteride. They're the same thing, really. They're just slightly different molecules, but they do basically the same thing. And what they do is they limit the conversion of testosterone to DHT. The side effects are related to having a lower amount of DHT in the body. And remember, that's a much more highly potent version of testosterone. So it does have other effects in the body, including affecting sexual function. So most men who take this will report decreased libido and erectile dysfunction. Those are some of the more common symptoms. Not everyone will experience this. Actually, I think the incidence is like 10% or 20%. So it's not huge, but it is something to consider for patients who might already be reporting those types of symptoms in this particular age group. It's not uncommon to experience decreased libido, erectile dysfunction. So whether you compound that with a 5-alpha reductase inhibitor is something that you might have to explore with a patient and talk to them about the risks. So how do we treat this? With mild to moderate symptoms, an alpha blocker alone is probably enough. Just because of the side effects related with the 5-alpha reductase inhibitors, you might want to hold off on those until the patient is either presenting with severe symptoms, they aren't getting a response from the alpha blocker, or maybe if they have a very large prostate upon presentation. If you palpate their prostate's quite large already, you might just want to go directly to that. You can combine some other things. The antimuscarinic drug tolterodine is an option that can work. And the PDE5 inhibitors have been shown to be effective as well. And we'll talk about those in a second. But the point is that you would get a dual mechanism that would also work for patients with erectile dysfunction. So especially if you're prescribing a 5-alpha reductase inhibitor and they're experiencing that side effect, this can counteract that and also work on some of their BPH-related symptoms as well. Okay, prostate cancer. I want to spend a few minutes on prostate cancer because it's a really common cancer, along with breast cancer. I think those two are, probably two of the ones that I think are worth spending a little bit more time on. Again, very common. Just like with any cancer, early diagnosis is key. The tumor growth is quite slow, and the metastatic spread is pretty slow as well. So if you catch it early, it's very survivable, very treatable. PSA, prostate-specific antigen, is the diagnostic tool. A high PSA doesn't necessarily mean you have cancer, but it's something we will look at more carefully with the patient. Digital rectal exam, so palpating the prostate via the rectum, is something you can do as well. And just one thing quickly as well, BPH is not cancer and cannot lead to cancer. However, you can have the two together. I think people say that like all men will get prostate cancer. That's not true. It's BPH, which is not a cancerous growth. So BPH related prostate growth is not the same as a tumor. It's most common in men over 50, so it does correspond with aging as well. Treatment options, there's a couple different things, and most of them are focused on some sort of androgen-related manipulation. So you have a group of androgen receptor antagonists. These are called anti-androgen drugs. Flutamide and bicalutamide are the two ones in this class. What they do is they inhibit androgen uptake and binding at target tissues. Abiraterone, or Zytiga, is a specific CYP enzyme inhibitor. This CYP17 enzyme was identified as the enzyme responsible for androgen biosynthesis, which ultimately inhibits the formation of testosterone precursors. It's a very, very expensive oral tablet. And then you have some other more heavy-duty drugs that are kind of thought as medical castration. They're essentially going to suppress testicular steroidogenesis altogether. So this is a more broad approach, whereas these approaches probably are a little more narrow focused and patients will tolerate them better, versus this is going to make it so the patient doesn't really have any testosterone being produced endogenously, or very small amounts. I guess your adrenal gland would still produce some, but it's cutting off the major supply of testosterone for males. Kind of talks about where in the body these different medications work. All right, so that's really all I wanted you to know. And again, cancer is more of a complicated picture from my perspective, because there's so much to do with surgical interventions and radiologic interventions. So from a drug perspective, it's not terribly complicated. You're mostly looking at ways to kind of block the androgen effect in the body. And so I would really just want you to be familiar with, we have anti-androgen type drugs that work in different areas that you could use for prostate cancer. All right, erectile dysfunction. Fairly commonly reported thing, and especially if you go into primary care, you're probably going to encounter this occasionally. So erectile dysfunction is prevalent, about 18.4% reported incidence in men 20 and older. So it can really affect men of sexual maturation age, of any age within that. And the root cause can be really variable. So it kind of depends on what you're looking at. But generally speaking, cardiovascular disease and diabetes will increase the prevalence of erectile dysfunction by up to 50%. BPH and hypertension can also have a slightly higher prevalence than the general population. There are also other things such as decreased libido, premature delayed ejaculation that can cause erectile dysfunction as well, or be related to erectile dysfunction. So decreased libido can cause ED. 5 to 15% of men at any time can have just generally decreased libido, and that can increase with age. So that's one way to maybe identify, is the patient just experiencing decreased libido? Do you need to maybe run some tests? This is probably a patient you would run a testosterone level on, see if maybe you need to replace the endogenous hormone. Without necessarily prescribing drugs directly for erectile dysfunction. Not to say you couldn't, but it might be, let's approach the root cause first and try the testosterone replacement. Other common causes in treatment involve psychological related. So if it's psychological or specifically anxiety related, that can be something that you treat slightly differently, whether with psychotherapy or anti-anxiety medications or even antidepressants, which is kind of funny because you think about that, not funny in the sense, but maybe kind of interesting, that'd be a better word to describe it, because if you think about the way SSRIs have a pretty heavy side effect of causing sexual dysfunction, but if you have a lot of anxiety and that's preventing you from getting an erection in the first place, taking an antidepressant might actually help and allow you to overcome the anxiety related response. So that's something that can be looked at in two different lights. And you also might have patients who are well maintained from a depression perspective on an SSRI, but are having erectile dysfunction because of that, and therefore they need some sort of additional therapy to overcome that, because you don't want to switch the SSRI. So there's a number of different ways to look at this, and it's kind of a double-edged sword there. Treating ED, first of all, trying to control those underlying things that are going to be increasing risk of ED. And then there's medical therapy too. Remember, we have medical side effects. We have psychological options too, addressing the underlying concerns. However, we do have medications that can treat erectile dysfunction. As you guys are probably all well aware, most people know the words Viagra and Cialis fairly commonly from advertisements or just layperson talk. There seem to be very common medication names that are thrown around quite a bit. But these are PDE5 inhibitors, so they inhibit the phosphodiesterase enzyme, specifically the subtype 5. And the mechanism is kind of, it's actually a pretty interesting mechanism. I can't remember how the story goes, but I believe these drugs were designed either as antihypertensive agents or as antidepressants at some point, and they found out that they worked this way. People were discovering that this had a different effect than they expected, and they're here we are now. The rest is history. So it's really important, I think, stating the obvious. These don't cause erections. If the medication caused an erection as soon as somebody took it, they probably wouldn't sell a whole lot of them. I don't think people would necessarily want that type of a medication. But what they do is they augment the body's natural response to sexual stimulation. So when they start out with the brain here, right? So when somebody is sexually aroused, your brain releases nitric oxide, which triggers sort of a downstream effect that causes some smooth muscle relaxation, which increases blood flow into the penis, which causes an erection. One important thing about this is phosphodiesterase 5 will slowly decrease the amount of cyclic GMP around, and eventually it'll reconvert over, and most people will continue to have an erection without a problem. However, what these drugs do is they actually block this mediator. So it makes it so that even, I think about it like, well, if you have some small amount of sexual stimulation, it's going to be much easier for a person to get an erection because they don't have that enzyme around to be able to decrease that cyclic GMP, because that's just always kind of going to be circulating. So it's going to be more potent in the body, making the erection more easily sustainable and easier to get an erection. The three drugs here, sildenafil, vardenafil, and tadalafil, are the ones that are on the market right now. There's actually one more, but I don't think it's used a whole lot from what I can tell. Sildenafil is Viagra, vardenafil is Cialis, and tadalafil is Levitra. Excuse me, sorry, I messed that up. Sildenafil is Viagra, vardenafil is Levitra, and tadalafil is Cialis. There's not a whole lot of differences between the drugs. The big one is the half-life of tadalafil. You have about a 17-hour half-life. So tadalafil will stay in somebody's system for a couple of days and be fairly potent for a couple of days. So for people looking for a more long-acting product, that's going to be the big benefit over something like sildenafil, which is relatively short-acting, where you take it maybe on the night you plan on having sex, and then it's gone the next day out of your system, whereas tadalafil would last, into the next day and longer. So it kind of depends on what the person would prefer. There aren't a lot of trials between the different drugs. There was a fairly decent trial between sildenafil versus tadalafil, looking at just preference and use, and 71% of the men in the trial preferred tadalafil, with virtually no difference in outcomes. Okay, so PDE5 inhibitors, of course, have side effects just like any drug. And you might think about these phosphodiesterase enzymes, they're all over the body. So not only might it interfere with other PDE5 pathways, but there might be other PDE inhibitors that generally get interfered with as well. Most common side effects are going to be related to blood flow in different areas. So flushing in the face, headaches, sinus congestion, and also it seems to relax I think is the gastric sphincter. I can't remember my anatomy very well, but anyway, can cause acid reflux that way as well. Hypotension is something that will occur in people, but usually it's subclinical. The biggest thing to be concerned about is if a patient needs nitrates. So for example, if they start to have a heart attack and they have to take a oral nitrate, that can cause a profound drop in hypotension. So that's just something that we want to make sure that's well aware of. Also, alpha blockers in general, if they're taking those in addition, that can compound the effect and cause extra orthostatic hypotension. There's some weird, rare visual disturbances. So with sildenafil specifically, people will report blue vision apparently that can resolve in a couple hours. It's not permanent. And there's a really, really rare chance of blindness. And I believe that's temporary, but I'm not entirely sure because I don't think it's super well reported with sildenafil and tadalafil. I'll report really, really rare instances of hearing loss too. Again, these are like almost 1 in a million type cases. Myalgia, back pain is really common with tadalafil, interestingly enough. Not sure about the mechanism on that. And of course, these drugs could theoretically work a little more than you want them to, causing a priapism. And so if a patient has a longer erection than they want, that can be something that would either maybe need medical attention if it happens to be long enough. Other things that can be done at home, PO pseudoephedrine, so over-the-counter Sudafed, has a vasoconstrictive property to it. You could take a larger dose of that to try and get rid of the erection. Other things like using your large muscle groups in your legs, squats, things like that could possibly divert the blood flow to other areas of the body. But if it's not getting rid of it, they might have to go into the ER, and at that point they will try things like aspirating the penis and removing the blood mechanically, which is not going to be a pleasant experience. So because of some of these side effects and how they might affect people differently, generally speaking, these medications are fairly well tolerated, and I think most people who use them would say that the side effects probably aren't worth the benefit of the drug is probably outweighs the side effect, hence why these have been super successful blockbuster medications for the respective companies. One thing to think about if you're prescribing these to somebody who's never taken them before is try something shorter acting initially. So don't necessarily go straight to CLS, but try Viagra. You could prescribe Viagra, and then at least if they have a lot of flushing or severe headache or something like that from it, that's only going to last a few hours, versus if they take a Cialis, then they're stuck with that in their system for several, at least a couple of days probably. Outside of that, there's not really any specific recommendations. It's mostly just patient preference. Do they want something longer acting or shorter acting? Other fun facts. Sildenafil is the oldest and most well studied. Some of the medications are quite often abused. I think abused is a bit of a a misnomer in this case, but I'll go with it anyway. I think the idea here is that there's people who don't necessarily have a medical diagnosis of erectile dysfunction, but just take these medications because for obvious reasons, I think, but some of them can also reduce post-ejaculatory refractory time, allowing people to have sex multiple times if they were to do so. But that's, again, I don't necessarily consider that abuse, because most of it would be, this would be just an effect of the drug. So I don't know. I think these have been really expensive medications, historically speaking. They used to be about $10 a pill, which wasn't too bad actually compared to some things. However, insurance coverage has also been fairly limited. When I used to work retail, which was a long time ago, most insurance plans would only cover a certain number per month. If they covered it at all, they'd only cover like 8 tablets a month. Or something like that. They had some restriction on it. However, there are generic versions out there. So sildenafil and tadalafil have been on the market for quite a while and are both available in generic forms. And they also have use in pulmonary arterial hypertension as well. So that particular branding of the product has actually been generic quite a bit longer than the ED branding of the product. So there are somewhat similar yet slightly different strengths available that are generic. So there are cost savings you can get with these particular products, but the brand name ones are still prevalent and relatively expensive. There are other things here that I listed that people can try. Just as a fun story, I used to work at a pharmacy that did a fair amount of compounding when I was a student, and we actually made these intercavernous injectable products. So basically you make a cocktail of things that promote blood flow to the penis, and then use a very small like subcutaneous needle, and the patient would inject it into each side of their penis, and then it would cause an erection. So before PDE5 inhibitors, these were really the only options. So now with these drugs, of course, they're probably going to be much more preferred than something that you have to inject with a needle into yourself. So just again, some fun facts to share with you guys. Oh, and I put this on here as a reminder. I think there's a lot of counterfeits of these products out there in the world. And this is a picture. I think this is one of my friends sent me this from a vacation they took. I can't remember where I got this, but it's just an example of a pharmacy in Mexico where they are advertising certain things you can just buy without a prescription. So I always think this is funny, not necessarily for the Viagra and Cialis ad, but more so for like you can go in and just get yourself, whatever antibiotic you want to, or just, pick up some Plavix, because certainly that makes sense to just go diagnose yourself with with the need for an antiplatelet agent. So anyway, I think there's a lot of probably counterfeit products out there on the internet and a lot of junk. My general advice would be, if you ever have a patient buying stuff from a non-vetted internet pharmacy, to be careful, because they probably aren't getting a real drug. Now, there are a lot of internet pharmacies out there that are doing things correctly. In fact, there are a lot of state restrictions have been lifted amongst like telemedicine or distance medicine now. So you can go online and get a virtual consultation with a real physician and a real prescription that goes to some real mail order pharmacy, and you get a legit medication. So certainly there are online methods of getting things like sildenafil, like Viagra and Cialis online, and that's going to probably appeal to a lot of people just because of the private nature of it, versus having to go into their real doctor and go to their real pharmacy where people may or may not know who they are. You can just go online and fill out some forms and get these medications. And there are again legitimate pathways to doing this, but there are also lots of other illegitimate ways to get medications, and just tell your patients to be careful. Male birth control. I thought I'd just throw this in there because we spent so much time talking about hormonal contraception. There aren't very many options that are useful for men at this point. Really, you're looking at vasectomy, which is only really going to be feasible for males who either don't want children or are done having children. Vasectomies can be reversed, but it's a fairly significant surgery, whereas a vasectomy itself is a pretty simple surgery. Reversal is much more complicated, and it's not always effective either. Condoms are, of course, going to be the barrier method of choice for men who don't qualify for a vasectomy and their partner doesn't have a birth control, or simply a male who doesn't want to expose himself to an STD. Makes sense. And then withdrawal methods, which, as we talked about during the hormonal contraceptive lecture briefly, don't have great track records, and you do have to be very strict about parameters and monitoring and things like that. Okay. Testosterone suppresses LH and FSH, excuse me. If you give enough, you will suppress spermatogenesis. So you could simply dose somebody with like a testosterone intermediate that eventually suppresses, or testosterone analog or something like that, that suppresses LH. So they've actually looked at different drugs that would mimic testosterone to suppress spermatogenesis, but not affect testosterone's other benefits that men would find problematic if you suppress. But the problem with this is, and if you compare the male reproductive process to the female, you end up with an incomplete picture. So a lot of times you have to either add more hormone to it, and ultimately a lot of these research showed that you could suppress spermatogenesis substantially, but it's very difficult to suppress it completely, just because you have to prevent hundreds of millions of sperm cells. So even if you could drop a man's sperm count substantially, yes, that would reduce their chances of getting a partner pregnant, but it's still going to make it a possibility. Whereas with female oral contraceptives, it's much more predictable. Not necessarily guarantee, of course, but certainly based on the research into male hormonal birth control, it just hasn't really panned out. There are some future options. I've read about them over the years, and I basically deleted this slide, off and on, because nothing ever pans out, unfortunately. So there's just not been a lot of great studies out there that show promise in this area. However, there is an interesting product that the University of Minnesota is researching, which basically, from what I can understand about it, manipulates vitamin A, which is a precursor to spermatogenesis. And so the idea is that if you can block something upstream that sperm need to develop that doesn't have to do with testosterone, that would be kind of like the holy grail, because you're not interfering with hormones, you're not going to have as many problematic side effects in a clinical trial. There have been some animal studies right now, and I've read that they're looking at doing human trials soon, but there's nothing out there yet. So that's really all I know as far as a promising study. There's probably other things in the works, and we could debate the merits of male hormonal contraceptives and the side effects they give men versus the side effects females get from combined oral contraceptives, because they're probably, from what on paper, they look fairly similar, but at the same time, there's lots of barriers in research when you have patients who aren't responding well or having too many side effects in the early phases. So someday we'll probably have something, but right now the options are limited if a man wants to prevent pregnancy on his own without the partner's involvement. All right, that's it. Thanks for listening, guys.